Hello, everyone. This is Dr. Angela Lynn and Dr. Lois Starr. We are medical geneticists who have a great interest in Myhre syndrome. I work in Boston at Mass General Hospital. Lois works in Omaha at the University of Nebraska. Technically, this is considered a lecture, a talk, but we would like to think of it as a conversation. We wish we could be there with you in person, sitting around a table and just being comfortable about this, because in some ways this is a somewhat uncomfortable topic. I need to thank the people who encouraged me to do this. I want to thank the people who live with Myhre syndrome who did ask some of these questions. For other individuals out there, you may think you had no intention of wanting to know about this. And so we chose to present it in this way as a talk, pre-recorded, that could be accessed by you at your convenience. And before I bring up the slides, let me give Lois a chance to say hello.
Hi, everyone. My name is Lois Starr. I'm a clinical geneticist from Nebraska, as Dr. Lynn said. I have a passion for Myhre syndrome that stemmed from meeting a couple of patients earlier in my career, and I'm really honored to be here and look forward to this conversation with Dr. Lynn. Thank you.
And as you know, we are truly a community, I hope you'll agree, of providers and of patients and families. And so we certainly welcome your feedback. If there are things that you think we did the right way, please let us know because we may continue to use this in our personal counseling. If you think there were things that we said that were not the right tone, not the right information, let us know that too. Slides can be easily edited. I hope everybody can see the slides. I've phrased this, may we talk about autopsy. This, of course, will be said with reverence and respect, and we're all seeking answers to questions. And that's a very broad phrase that can apply to many different things. So the purpose of this talk is to answer the question, what is an autopsy? How does it help? How could it help me, my family, or others? How would I plan for myself or a loved one? Are there different types of postmortem examination? I'm going to let Lois take a turn. We'll probably alternate.
Oh, sure. So, in this talk, we are thinking of you, the families and friends who have lost a person who had a diagnosis of Myhre syndrome. And this question comes up sometimes not at the most convenient time. And so, we want to thank those that first ask the questions. What can I do in the event of my death or the death of a loved one with Myhre syndrome? We are grateful that you are allowing us to present this information. We know it's never a good time. It's always awkward and complicated to discuss these things. So we want you to be prepared when the time comes. And we hope that this can be reviewed in advance. But if anyone is reading this unprepared after the death of a cherished loved one, we extend our most sincere condolences.
Lois and I are very affectionate people. At this time, if there is somebody, we wish we could give you a cyber hug. That's the best that we can do right now. So what I'd like to do is show you the way we began this process. It all began with a question, questions to me, and I asked the help of Kate Weirs, who I think is a very wise person. And I said, how do we begin this discussion without jumping in with a lecture like this? And she said, let me frame it this way. And I thought it was so clever. She framed it in the context of life expectancy, natural history. And excuse me. And she mentioned that as part of this, that autopsies can help a family bring closure if there was any question about the end of life or to confirm what was suspected. In addition to help the family, an autopsy can advance the understanding of the disorder and allow clinicians to better understand disease progression, improve management, and potentially help others in the community. This examination will always be done with reverence and respect. I thought you might be interested to know how each of us became interested in talking about autopsy. What was our experience? I trained first in pediatric cardiology. I practice now as in medical genetics. And part of the core of being a cardiologist is to always check the heart literally with an echo, but in the event of a death, to actually examine it. We did this almost every time there was a death. And so I was used to handling hearts and thinking about this as a way to give us information about what we did right or wrong. I also work in the field of what's called birth defect surveillance. These are registries around the country where we count up at birth the children who are born with different defects or syndromes. And we also talk about stillbirths and other losses. And several years ago, I worked with a colleague of ours, Elsbeth McPherson, to write a paper that had to do with alternatives to autopsy for fetal and early neonatal deaths. That's a mouthful. But the point was, we wanted to make people aware that there are different ways one can obtain information about a loss, whether it's a stillbirth or a live birth. And in fact, when you look at the different causes of death identified in cases with and without autopsy, the point is that when you do have an autopsy, you're able to be uh, more successful in obtaining an answer. I've also had a chance to work with other syndrome support groups. I think all of the geneticists that work with Myhre syndrome, we come to you from a different pathway. I like to think that that's what makes us have expertise in working with Myhre syndrome. And I worked with a disorder, and I still do, called Costello syndrome. I had written an article about the clinical, pathologic, and molecular analysis of the heart abnormalities in Costello syndrome. It's a different pathway. And part of the core of this was to look at a heart specimen. There were very few of people who had passed away, and to compare the type of cardiomyopathy to other cardiomyopathy. Now, again, this is not the same as in Myhre syndrome. It's just an analogy. I also work with the support group for Turner syndrome, and we created a paper that was stimulated by a woman who lives with Turner syndrome. And I can actually say her name. It's Barbara Flink. And Barbara said to me one day, she goes, "I don't know what to do when I die." And she had this little box, this little quote. For many years, I have been interested in autopsy. My parents were both adamant that they wanted any usable body parts donated when they died, and we had many family discussions, some of which were quite humorous on the subject. I'm a strong proponent that every family should have this kind of discussion about the inevitable long before someone is on their deathbed. My mother donated her body for anatomical study when she passed away 5 years ago, inspired me to do the same, hopefully not anytime soon. So it was really Barbara that sort of gave us the nudge to create a team in which we talked about donating our bodies to science, a discussion about autopsy and organ donation in Turner syndrome. So the focus was slightly different. I'd like to turn it over to Lois, and I need to let you know that uh, a paper that she wrote in 2015 was really seminal. It really played an important role in how we think about Myhre syndrome.
Thank you, Angela. So, yes, my background is also as a medical clinical geneticist. I really enjoy working with aortopathies in particular, and those are conditions where the aorta itself often can grow too big, but in the case of Myhre, often is too small or too stenotic would be the other word that you might have heard for that. And I love this area because there's a lot that we can do for these individuals that have an aorta that could either benefit from surgical intervention or other medications. And so this is an area of genetics that it's probably my favorite. And so Myhre syndrome, getting to know a couple of patients early on in my career was a perfect fit for me in learning more about these important pathways of connective tissue. Um, the first manuscript that I was involved with that encompassed Myhre syndrome was this clinical features and restrictive cardiopulmonary complications. And Dr. Lynn was a huge help with this manuscript as well. But the patients that were described in this manuscript included two females that struggled after transplant and unfortunately, they passed after that, and we learned a tremendous amount about the fibroproliferative processes with Myhre syndrome from that. And another individual from that manuscript also passed, and her family was from where I'm from. And we had diagnosed her locally, and her family was very interested in what their daughters could do to help contribute to what we knew about this rare condition. And so, with the most heartfelt respect, we did have an autopsy where I also attended that, and we gathered some more information about the tissues and um, things that we could see with our eyes that you can't see when you're doing different imaging studies. So there were things, very valuable things that we learned from that. And that was a restricted autopsy, or one that didn't involve everything, but it did allow us to look at several organs and um, respectfully take a look at the tissues to get a better idea of the disease process of Myhre syndrome. And so that information, as well as other pathology information that we gathered from many of our colleagues, we combined into this more recent article that you see below.
And this review by Lois and our team is really important. It not only showed us in what ways people had tried to obtain tissue, look under the microscope, examine a specimen, but it helped us learn the gaps. And sometimes that's how learning proceeds, not by what we've done, by what we need to do. And, I hope the listeners don't mind that we're sharing these personal stories. In my experience, most patients have told me that they'd like to know, how did we get into this? They're not asking for credentials, but they just want to know the personal story. Just as we learn your personal stories, we're sharing ours too. And I just want to say that the way I got into Myhre syndrome, how did I come to this, was really because of review of an autopsy report. My senior colleague had given me a chart. He said, we don't know what this woman has. It happened in the 1980s and 90s. Could you work on it? And I was just absolutely intrigued. And it was this person, the death of this woman, that allowed me to learn about Myhre syndrome. So the definition of an autopsy is a medical examination of a body after death. And sometimes people feel it's more precise to say a post-mortem examination. If you don't mind, I'll say autopsy just because it's shorter. And the purpose of the autopsy is to help the family obtain information which could answer questions about the death. There are many questions about Myhre syndrome that can best be answered from autopsy. I should also say that there are times where a family will make a donation saying, I would like you to perform this autopsy for science, for your own understanding, which is, of course, much appreciated. But to let you know, that is never the main reason. The main reason is to try to help the family. And in general, an autopsy should be considered for a person with any rare disorder. For any rare disorder, by definition, it's uncommon, and we just don't have enough information, including Myhre syndrome. And it's especially important where there are special organs involved, such as the heart, aorta, lungs, kidneys, nervous system. The findings of some autopsy reports could be so important that they might be reported in a future article. That's not the intention of doing the autopsy, that might be sort of a secondary part. I'm going to give, let's see, I'll do this because these were my slides. A quick review. Those of you watching know this better than I do reciting them, but growth in Myhre syndrome is usually on the small side, a compact habitus, a compact build. But we do know that there are patients with the arginine variant who can have completely normal height. The characteristic facial appearance changes over time. And I thank the mother of one of my patients for creating this magnificent montage, which just shows a child at every age, and it's shown with such love and with so much better accuracy than if we took a picture in the clinic. Lung disease, we think about not the lung tissue itself, but the chest wall, which can be stiff, can be tight breathing. There can be premature puberty. There can be skin problems. And as you know, again, listening to this, connective tissue proliferation, stiff joints, straight spine, arthritis, cervical vertebral fusion, thick skin, thick scars. And there can be what we call functional features. The first group are things that are structural things that are different, but what doesn't work too well? Let me give Lois a chance to read through these.
So we know that most body systems are involved in Myhre syndrome. So including the gastrointestinal, we've seen strictures, especially if there's been any trauma to the tissue or any surgical interventions. Sometimes there are strictures and stenoses that can occur after that. Issues with breathing, we see obstructive but more restrictive breathing patterns, difficulty, tightness with breathing, difficulty with swallowing. Many of the individuals with Myhre syndrome have vision issues from refractive errors to astigmatism, as well as other ocular problems. Hearing loss, as you know, is almost in everyone seen at some point. Most often there is a combined type of hearing loss, but pretty much always at least some element of what we call conductive or something where it's a physical rather than a neurologic hearing loss. And then multiple neuropsychologic um, neurodevelopmental issues, including developmental delays. Most would say that the individual in their family with Myhre syndrome has some cognitive struggles more so than other members of the family. Autism spectrum disorder, maybe autism hasn't officially been diagnosed, but there are at least recognized some social disabilities. Attention deficit hyperactivity disorder is something we see frequently. We see depression diagnosed not infrequently, especially in our adults. Anxiety issues are common. Obsessive compulsive disorder has been noted several times. And then even on the more extreme end of mental health issues, things like schizophrenia seems to be more often than in the general population.
Thank you, Lois. And to the listeners, we tend not to think of these challenges as specific boxes. We tend to think of this as a brain in front of us, which has been impacted by the SMAD4 gene variant during development and then during growth too. So we feel that these are in some ways related, but that doesn't mean that if you have, say, ADHD, you will get schizophrenia, not at all. I wanted to acknowledge the less common features, schizophrenia, OCD, and the others are more common. So for the internal features, I started by talking about structural things that you can see, the functional problems. These are the internal things. So the way we can image the heart and the aorta begins with listening, taking a history, doing an echocardiogram. And as you may know, sometimes we use more additional studies such as a CTA or an MRA or catheterization. And so we see problems with the aorta, coarctation, which can be a discrete narrowing or more diffuse narrowing. Segmental stenosis means narrowing of different branches of the aorta. Diffuse aorta hypoplasia, which is usually mild and common. We can see mild heart defects, ASD, VSD, PDA, some left-sided defects such as the aortic and mitral valve. Rare but reported is tetralogy of Fallot. The pericardium is the thin sac that holds the heart, and it can be inflamed. There can be fluid. It's uncommon but real, maybe about 10%. Restrictive cardiomyopathy refers to the heart muscle. The muscle is neither thick nor thin, but it's stiff. And this is rare, but we are observing it. And the brain can be involved in different ways. Not major brain structural abnormalities, but there can be some small problems, and the spinal cord too. The lungs, the pericardial thickening. And hearing loss is an interest of mine. I've given a talk on it, and I think I just have a little slide here to illustrate that we can have hearing loss, that you can evaluate based based on talking to a person, of course, by doing a tympanogram and audiogram, and by doing imaging with either a CT or an MRI scan. But in fact, we know that the what we're doing is we're looking indirectly, and that it would take actually an autopsy, an examination after death to be able to really know for sure. In other words, these kind of images are quite beautiful, and they really do show what the structures look like. But we're not able to do a biopsy of the inner ear. We cannot put a needle in. We could, but the risk would be, would be there. So let me give Lois a chance to tell you a little bit about autopsy.
So, for autopsy, ideally, this would be part of all of our life plan. The discussion to pursue the option of an autopsy can come up at a very difficult time right after someone has died. And so ideally your family, friends, spiritual clergy, and healthcare providers might know about all of our choices on whether or not to have an autopsy before we die. So when an autopsy discussion is planned and those decisions are known ahead of time, it can relieve the loved ones of making a decision when the grief is so raw and fresh. So there are several different life situations that have been published before that might prompt the discussion of an autopsy. And if these come up for you or for your family members, it would be an ideal time to let people know what your decisions are. So when there are deaths of a fetus or a baby, sometimes this can come up. If there is a sudden or unexpected death, this is probably one of the most common times because, of course, understanding what caused the death is of high importance to all involved. Sometimes it can be a preoperative discussion, knowing that there could be significant complications during a surgery. The end of life care discussions is an excellent time to discuss autopsy as well. Any educational session or when this comes up in estate planning, or also when research studies are brought up, this can prompt the discussion as well.
Thank you, Lois. And folks listening, I hope you can understand that the examples represent an example of many different situations, not just Myhre syndrome. And I know one way for me to relate to this topic is elder care, having cared for parents, and maybe many of you out there. So it's not the same as Myhre syndrome, but it puts me in that frame of mind. And so, what I would suggest is that you share your thoughts with your family and with others. You would share this information, your wishes, with your personal providers. For example, your pediatrician, your cardiologist, geneticist, and of course your Myhre syndrome providers. If you do have someone that you could talk to. If an autopsy is desired, you would identify a local provider, the primary care doctor, the specialist who can oversee the process. This doesn't mean doing the autopsy, but helping you enact it and ensure that it's carried out to your wishes. This would be somebody who would respect your plans for a funeral too. And we are here, Lois and I, and those of us at Mass General, to assist, but we can't take the lead. This has to be initiated by the family. I hope you can understand that. The physicians of the Myhre Syndrome Foundation will be able to help you discuss the autopsy with your providers. However, you would need to give the consent and ask your specialist to contact us. We are not able to initiate this discussion. So again, to repeat, despite our interest, our concern, our willingness to help, we can't go to people and say, this is what you need to do. It would need to come from the family saying, I would like you to involve Dr. Lynn, make an introduction. And I know that a time following death is a very difficult time. And I wouldn't expect you to remember all of this. And Kate Weirs has been very helpful in sort of acting as sort of the middle person. And there's no cost to the family for an autopsy, by the way. You will need to provide a signed consent form that is provided by the hospital that explains your wish to have at least the MGH doctors involved, and it could be Lois as well. Prior to helping a family who is new to us, we would need to review some medical records. For example, the most recent cardiologist or geneticist summary or report from a hospital admission. So we would want to be involved, but we need some preparation. We can't go into this without being informed. An autopsy report eventually will be provided to you by the hospital, and as I say, most cases, but it's very difficult to know the timing. It varies based on the hospital, the intensity, the autopsy, the findings, the discussion. And the report would be shared with us if you have given consent. If you've given consent. And because an autopsy and death is such a precious moment, there are people at most hospitals that are involved with this. It's called decedent affairs. And they're protecting you and your privacy, even though you may want to just casually say, oh, tell Dr. Lynn it needs to be more official. If the information is found to be significantly important, we would discuss with you the possibility of reporting the findings as a medical report. Of course, this would be anonymous. And so, some general information: a standard autopsy at an academic institution would follow their pathology department's protocols. Pathologists have a protocol, they follow a plan. Details would be provided by the consenting pathologist. An autopsy can be performed at most hospital pathology departments, but at smaller and rural community hospitals, they may not be able to do this immediately. There may be a pathologist who comes to the hospital rather than somebody in house. The autopsy can be limited to the heart and the lungs, as Lois explained to you, or in any way that a family, requests. So there are ways to do what we call a non-invasive or limited invasive autopsy: heart, lung, photographs, a skin biopsy. These can't be done too long after the person passes. They could be done in a few hours, but for some people, that gives them some peace to proceed, but yet not think about the complete autopsy. And we understand that. A body that is not embalmed cannot be transported across state lines on airplanes, but can be transported by ground. In the United States, some deaths may involve the state or the medical examiner's office when the attending physician is unable to state a reasonable cause of death, or if the person has not been seen by a doctor for 20 days prior to death. I want to just give you a chance to think about that. So, if a person who dies in the hospital seriously ill, they would not need a medical examiner. If somebody had been actually well at home, had not seen a doctor for 6 months, it actually would be what we call a coroner's case, just so that we can establish, what the correct cause of death was. And in general, the family pays the funeral home for the transportation to and from the hospital. The non-invasive autopsy is a concept we've been hinting at. The comparison between a conventional autopsy and a minimally invasive one is that a conventional autopsy involves dissection. Minimally invasive does not involve dissection. Conventional, examination and removal of entire organs. Minimally invasive, small samples of biopsies of many organs. Conventional autopsy photographs are usually done. Histology means pictures of the slide. Minimally invasive would actually ask for a CT scan or an MRI scan to be done after death. Now, this is not possible at all hospitals. This is something that, again, could be discussed prior to death to carry out somebody's wishes. And there are different tissues that can be made available from a minimally invasive autopsy: blood, cord blood, brain fluid, middle and inner ear structures, liver, lung, bone marrow, skin, heart, thyroid, aorta, small intestine, ovaries, kidneys, pleural effusion, ascites. I'm just giving you a variety of different organs and tissues that we can get from it. And over here, this actually referred to Turner syndrome, was the point of doing that. So there is a handout that is available to you. And we created it at Mass General, and we had several of the board members review it. And it explains a lot of what we're saying right now. What is an autopsy? And why should one take place? A step-by-step guide, as I said, pretty much what we really just discussed with you now. There's a section called General Autopsy Information for Postmortem Examination. And this is available from Kate. We didn't post it on the website, but she does have it. We also have something special that's sort of a doctor-to-doctor communication. So at Mass General, we created actually a checklist of different places to check, how to check, specimens to obtain. It's too technical to show for a talk like this, but it is available, again, doctor to doctor. So if a pathologist at a certain hospital was going to do an autopsy, they would contact us to say, can you share this? Can you talk to us? Can we do a Zoom conference? And to summarize, I'm going to let Lois conclude maybe.
Sure. Um, we are grateful for this opportunity to be able to talk to you. If you chose to watch this, maybe you're in a situation where um, you're thinking about what would we do in the case that a loved one with Myhre syndrome passes, and would there be a way to contribute to the knowledge base? And so we want you aware of this information, but of course, this is a family decision, and this is something that's completely up to the individual and the family. We only want to serve as a resource for information that you might be looking for if you're in that situation at this time. So we hope that this is helpful. And if you have any questions or looking for any further advisement from Dr. Lynn or I know that we're more than happy to provide further information.
And as obvious from what we've said and what I show you, we thank you for listening and for giving us the feedback that I hope will make this a better presentation. And as I always do, I need to thank all the people that have helped me. We have our MGH Myhre Syndrome team. You've seen this photo directory, the Myhre Syndrome Foundation, including Dr. Starr, of course. And then this is a photo of the professional advice, excuse me, the board of directors, referring physicians, parents, patients. This is our international board. Where's Dr. Starr? There's Dr. Starr. And we get tremendous support from, at least at Mass General, our own fund, as well as the Myhre Syndrome Foundation. And I thank you for listening.